Thank you. Good afternoon, good evening, wherever you are. Um, I really think Spark is a wonderful study club, and I can see it exploding. And Donovan's obviously a great leader in the dental field, so it's really a privilege to be able to speak to you on a topic that is obviously very interesting, very up and coming, constantly changing. Clearly cannot be digested in full in an hour. But I would love to engage you in what I think would be an interesting and pertinent conversation for the next hour. And so please bother me, challenge me, ask me questions as needed, and let's get started. So I am a general dentist in the world of dentistry, but in the world of medicine outside of dentistry, everybody calls me dental oncologist because I trained in a surgical and prosthetic fellowship after my GPR in dental oncology at a cancer hospital in New York City. And since then, in the last 14 years, it's been a mix of, private practice, doing dentistry, doing implants so I can make money, pay my bills, pay the student loans, pay the mortgage, you know, but at the same time, really focusing on medically complex patients, especially folks, that are waiting for radiation or had radiation or chemo, folks that are waiting for bone marrow or solid organ transplants, folks that are quite literally missing sections of their jaw and that had fibulas placed, and now they're coming back to us and saying, "Hey, I'm a cancer survivor. I went through all this, but now I want to eat and live with dignity and be able to go on job interviews and, chew on a steak." And the incredible power that we have as dentists, especially if you or I are trained in the surgical and prosthetic rehabilitation, it is arguably just as important in a different way as oncologists that are literally saving the lives of these cancer patients. So if you have some interest in dealing with medically complex patients, including cancer survivors, many of whom are asking for implants, then please come join me in a couple of weeks. It's one of my areas of passion. I am required to give a financial disclosure statement. I am not being paid for this lecture. Spark is wonderful in many ways, but one of the cool things about the study club that Donovan's starting is that there is no corporate sponsorship for these talks. You will see some logos for Linkstone Implant Academy. That is my study club. And we just celebrated our 50th live surgery course in New England as well as in the Dominican Republic. And we train in small group settings, mostly general dentists who want to learn how to place implants restoratively driven and to treatment plan properly. I am a KOL. So outside of this lecture, I am a paid speaker for various other implant companies, including Megagen, Dytron, Nobel, Hyos, Neobiotech, and Z Systems. And those are my current roster of implant companies. Other than that, I have no other significant financial relationships to disclose. But I am proud to say that I am not beholden to the highest bidder. Some implant companies pay little, some pay more, but I've never decided upon which systems to use based on who's paying me. And so I'm proud of that. And Linkstone has always been implant agnostic, is what I've always called it. My first implant 15 years ago took me 3.5 hours to place, and it was an implant direct. This is what my residency director wanted me to place. I said, "Okay, no problem, Dr. Rotunda, I'll place it." I like to think that it was placed properly. It was mesiodistally in the right place. The buccal wall was kept and the depth was good. Torque was fine. I didn't burn the bone. It wasn't a spinner. I got good 25, 30, 35 Newton centimeters of torque. But the stinking thing took me 3 hours, 3.5 hours, because this was my first time where I am actually doing everything from treatment planning to actual placement to even thinking about, am I sticking a cover screw or a healing cap, right? In the middle of this procedure, the patient says, "Hey man, I got to go feed my meter. I got to feed my parking meter. I'm going to get a ticket." And so I go, "Afnan, well, what the heck, man? Like I'm doing surgery here." But lo and behold, the guy gets up, feeds the meter. And back then it was quarters, right? Parking meters on the street outside of the health center. And it would have taken me only 3 hours, but it took me 3.5 hours because of that. But it took a long time, is my main point. Today, as you guys may already know, with the advent of technology and enhanced accuracy and precision, which means not only is it going in the right place, but it's going in the same place that you want it to go to consistently, you can do a full arch surgical case in 3 to 4 hours. What used to take me 3 to 4 hours freehand will now take 45 minutes, right? And I'm not a fast dentist. I like to take my time. But to do that, you obviously need a combination of technology. As you know, you need a CBCT generated DICOM file. You need an intraoral scanner generated stereolithography STL file. And those two are the basic components. Of course, you can have additional files, a facial scan. You can have what's called photogrammetry. But if you have a surgical guide with a restorative plan, right, that's the key. So if you guys are restorative dentists that are trained in surgery, then you are the expert, right? You are the specialist. Because as amazing as oral surgeons and periodontists are, they're not going to be restoring these cases for the patient, right? It's up to us as general dentists with surgical training to be able to plan the surgery with the final teeth, positions, amount of bone resection in mind, so that we can have accurate surgery. And if you choose to go this route, then you'll have less pain, less bleeding, little to no flap, faster recovery, and arguably a faster procedure, sometimes same-day teeth, and arguably a happier patient, and sometimes higher production and greater return on investment for you. Now, to do this, you obviously need a CBCT, you need an intraoral scan, and you need some equipment. But innovation and industry partnerships, with whichever implant systems you are using now, I don't believe that there are that many critical differences between the systems, meaning they're all to some degree evidence-based. They are, as long as you get the support and they work in your hands, if you can back it up with a protocol for your office, then I think really the implant system doesn't matter as much, but the treatment planning matters, right? So with the innovation, partnerships with your reps, with the industry, and if you're data-driven and you're presenting evidence-based care, then full arch can be so much more than what it used to be 10, 15 years ago, where everybody was doing all on fours, right? We were treating everybody in a cookie-cutter approach, removing a lot of bone, placing 4 long implants at a certain angle, and hoping and praying that this would be great. And 95% of the time it worked well. But we are seeing 10, 15, 20 years later that a small but growing percentage of these cases are leading to peri-implantitis, mucositis, failure implants, loose implants. And now, no wonder so many of us are engaged in zygomatic implants, pterygoid implants, transnasal implants. And so all of that is wonderful innovation, but to the patient is incredibly aggressive and invasive. And so if you're starting out on your full arch journey, I imagine most, if not all of you, are placing implants to some degree. But if you want to go from the onesies and twosies to the full arch, then really full arch implantology is so much more than just getting a guide and sticking 4 or 6 implants in. There's a big difference between having a lab tell you, hey, let's do 4 or 6 implants and let me just spread it out across the arch, versus you dictating to some degree, hey, lab technician, digital planner, you're an incredibly important and smart person that's part of this care. But let me tell you where I think the implant should go. 3, 6, 7, 10, 11, 13, whatever the numbers are. Let me tell you what I think the sizes need to be. And ultimately, let me tell you whether it's FP1, FP2, or FP3, right? Which has a lot to do with how much bone you're removing. And then finally, let me make the decision right up front, even before I even get the surgical guide back, whether I'm going to be doing a full arch, hybrid, whether I'll be doing a roundhouse, whether I'll be doing, 2 segmented bridges, or whether I'm going to section it into 3 different components, right? There's a big difference, pros and cons to all of those approaches. And even the type of metal that we're using. Now there's a growing movement, even though it's still a small percentage, of not everyone needing and being the best candidate for just having titanium. Ceramic implants have a weakness. Literally, it's a little weaker. There's a higher, the literature states that there's a higher rate of fracture. But in my hands, now it's a full 10% of my cases where I am reaching for that zirconia implant. Because a lot of these patients are coming with radiation to the head and neck, and they're at an incredibly higher risk of osteonecrosis of different varieties. And there's also a movement towards holistic and metal-free dentistry. And there's also a growing level of evidence for ceramic implants. It's still about 8 to 10% of my cases, but I wasn't doing any ceramic 5 years ago. And now we're doing it. And there is arguably, if you do it the right way, better soft tissue response. And now there's a movement towards, can zirconia ceramic implants be used for even full arch? Something that I would have never imagined 3 years ago. And now we're starting to do these cases cautiously. But that means I have to treatment plan, right? I'm not just saying, hey, lab technician, digital planner, let's remove 6, 7 millimeters of bone and just cut it off like it's nothing. And then let's stick the 4 biggest implants I can and let's give the patient same day teeth and never see them again. You know, so a lot of it's planning. If you plan well, then even if you're sticking 10, 12 implants in an arch, it should be relatively predictable, right? The outcome should be relatively predictable for you, right? And so now we're at a point where we can do zygomatic implants through guided surgery. We can do pterygoids, transnasals. We can even do FP1s, where we're not really removing very little to no bone, with the goal of giving a patient a fixed option that really resembles or biomedically is very close to what the patient had before the teeth were broken, worn down, or carious or infected. And we're not giving them, an inch of pink every time with a very heavy prosthetic, right? And so I do want to give you an example. Even as I'm providing pre-cancer clearance, and you guys all do this. We as dentists, we see patients coming in, they're getting ready for some kind of heart surgery, cardiac surgery, valve replacement, whatever. And the physician sends the patient, or the patient comes to us and says, hey, I need to get my dental clearance before I can go in for my knee replacement. And it's the same thing with patients getting ready for grueling 6 to 7 weeks of radiation for tongue cancer, throat cancer, thyroid, what have you, right? Many people that I speak to, and certainly, I'm 43, but people in my age group and even younger, certainly older, when I ask them, in dental school, what did you learn about pre-cancer clearance? And the most common response I get from dentists is, yeah, you're supposed to take out some bad teeth, do a cleaning, and make them a fluoride tray, or give them some extra strength fluoride, Prevident, right? And I say, no, that's not how it is these days. Patients that are coming in for dental clearance, if I send them out and they get their chemo and they get their 6, 7 weeks of radiation for the rest of their lives, right? They're going to be at risk of osteoradionecrosis, where any extraction, any gingival gum surgery, any implant placement renders them at risk of developing, gums that won't heal, right? And so sometimes, and I do this, once or twice a month now, as part of the dental oncology clearance, I actually talk to the patient about doing implants. And this is an example of a patient where I said, hey, this is the one last chance in your lifetime where you will have zero risk of osteoradionecrosis. So let's do full arch implants. I can talk to your radiation oncology team. I can talk to your medical oncology team. They'll give me a couple of weeks if I ask. But then I don't want to delay them starting their chemo and radiation either. And so what do? Guided surgery, right? CBCT, intraoral scan, photogrammetry, use a 3D printer, use the lab, get the guide made, and then pre-order the abutments and the PMMA teeth so that I can load the teeth on day one, right? And I say, hey, we've come to the age of even pre-radiation clearance involving full arch implants. Think about that, right? This isn't your, hey, let's just give you some fluoride so that, come back if your jaw is really painful because the radiation is going to really zap your gums and you're going to have to swish some salt water. That's not what this is about, right? And so in one 2-hour visit, we were able to do extractions, implants, custom abutments, and a temporary full arch bridge, and the patient is now ready for head and neck radiation to cure his cancer, base of tongue cancer, squamous cell carcinoma in this case. And I like to think that we limited his risk of osteonecrosis, at least in the mandible, for the rest of his life, right? Hopefully the implants will do great too. So just a quick word on the basics of doing guided surgery for full arch especially means, you should invest in some technology that will give you a return on investment on day one. And so in my opinion, and this is subjective, my personal opinion, a CBCT is the first thing to consider. They are as low as $40,000, $50,000 for brand new units now, right? And then followed closely by an intraoral scanner, because these two things will help you with endodontics, it will help you with crown and bridge impressions, it will help you with night guard impressions, and then a 3D printer, because frankly, these things are getting cheaper and cheaper. and so that you can print temporary full arch teeth. You can actually even do crowns for long-term temporary use. And so now the sky's the limit. And so if you have all three, great, you're ready to rock and roll. If you have none of the three, then please consider getting an intraoral scanner or ideally a CBCT, because the CBCT really gets you going surgically and endodontics as well. But if you have all three, then you're ready to go. And if you have a milling machine, then I think you're golden. There's other toys you can get. That you can get a facial scanner, you can get a photogrammetry unit. There is a an intraoral scanner made by Shining 3D that is now combining the traditional intraoral scanning with scan bodies with photogrammetry, right? The flags, the dominoes. And so I think that it's actually very accurate, surprisingly accurate. And the cost of that has really changed the way we think about, the hurdle towards getting a photogrammetry unit, which used to be, 2-3 times more than what it is now. And so, yeah, now is a great time for you to venture into full arch dentistry without the fear of having to buy so much equipment and spending so much money. I wanted to show you that another cancer patient, and this is a patient who had a head and neck cancer, was part of a clinical trial and had a recurrence, so was now getting ready for head and neck radiation. So he presented with this. Now, when you look at this, you realize his teeth aren't terrible, right? I mean, there's a lot of crowns and some open margins, some endo, some crowding. There might be some recurrent decay. There's obviously some missing teeth, but the patient and his wife strongly, strongly wanted to avoid the risk of having dental problems after going through a second round of cancer treatments, right? So again, he went through grueling clinical trial chemotherapy, and then now, several years later, because of a relapse, oral tongue cancer, now he's being considered for head and neck radiation. So they wanted all their teeth out. And so I said, okay, I tend to be conservative, but in this case, I said, you know what, given your age, given your medical history, I don't want you to worry about dental problems. Let's take your teeth out and give you implants. I also don't want to delay the start of your radiation. So let me do guided surgery, right? And so we got the guide. In this case, I used a lab called Rowe Dental Laboratory. I do recommend them highly. It's not the only lab, but they're one of the good ones out there. And, the second visit, we were able to place 12 implants, right? Got the cylinders on. I left 2 implants where I wasn't very happy with the primary stability and the torque. And then I delivered a same-day 3D printed PMMA teeth, and the patient was happy, and he was ready to go on his radiation to cure his cancer recurrence. And so I like to think that even though it was aggressive, his life has dramatically changed. Number one, he has one less thing to worry about. He can now focus on getting radiation to his head and neck region and not have to worry about future dental problems. This already one-time cancer survivor hopefully will not have dental complications or need any more jaw issues for the rest of his life. The implants need maintenance, but the risk of osteoid necrosis is now minimal to none. And so he has happily reported that he has finished his 6.5 weeks of radiation and he's again cancer-free. But really, we as dentists, including all of you guys and myself, please take pride in knowing that when a cancer patient, and I deal with cancer patients a lot, right? But you can substitute cancer with any medical complexity, any life stressor. When they're going through a medical issue or a life stressor, sometimes teeth, your smile, oral health takes a back seat. We all know that. Patients sometimes fall off, they don't come back for their recalls, they get their implants done and we don't see them for several years. We see that. But let me tell you from the perspective of a dental oncologist, patients that survive their head and neck cancer and even breast cancer who are taking bisphosphonates, once they're done with their chemo, radiation, surgery, transplant, all that stuff, they care so deeply about being able to chew properly, enjoy every meal. They already know that their life expectancy may be shorter, right? And if they have to get a couple teeth pulled, now they want to replace it. They're willing to pay premium for these implants. And these are some of the most health conscious people that care about, Dr. Lee, I have dry mouth already. My teeth, I am tired of maintaining them, getting root canals and crowns every year. Would you consider doing implants for me? My general dentist tells me that I'm not a great candidate because I have chemo and radiation. And I tell him, hey, come, let me help you. Let me get the information that I need from your cancer team, the oncologist team. Let me measure the dosimetric contouring data, and I think we can do implants. And so I got patients flying in from different states. I'm just a freaking general dentist in my 40s who spent 2 years in a cancer hospital, and I'm not any better or worse than any of you guys in placing implants. But the only benefit I think I bring is that I care more about treatment planning and thinking about every patient differently and not in a cookie cutter manner, right? I think deeply about whether to place 6 implants or 5 or 7. I don't just put in, I don't, if I'm doing an overdenture case, I'm not just putting 2 implants right in the middle, symmetrically placed. I think deeply about the bone density. I think about whether to remove bone or not, right? I think about FP1, FP2, FP3. And I think deeply about the implant size for BIC purposes. And so this is what I want to encourage you guys to do. I am realizing that many of you are already placing implants, I'm sure. But if you go into full arch, you as the treatment planning doctor, you are the specialist, right? And even if you refer the case out to a surgeon, to a periodontist, if you are telling him or her, hey, in this case, if we can fit a 7th or 8th implant in this arch, I think it makes sense because the guy's a bruxer, right? Or because the person has osteopenia, whatever the reasons may be, right? Because HbA1c is now okay, but even 6 months ago, she was struggling with diabetes and she just recently quit smoking. Whatever the reasons may be, that is the difference that makes you the specialist from a treatment planning perspective. So I have an MD friend who's a trauma surgeon, and he and I are good friends from high school, and he lives out in Madison, Wisconsin. I talked to him. He knows a lot about dentistry. He says this: you guys do microsurgery on awake patients who spit and move all day long, and a filling only costs a few $100, right? He thinks it's crazy that we dentists, we're doing literally surgery in a small hole, in a freaking dark hole, with a little bit of light, on a site where the patient's moving and there's different types of liquid coming out at us, right? And this is his experience where he got a filling done. He was surprised it was only a couple $100. So my point is that our ability to not only place implants, not only restore crowns and bridges and full arch prosthetics, but to do it together, there's incredible value. And I hope some of these examples I'm giving you with full arch, especially using cancer patients, drives home the point that we are some of the best surgeons and cosmetic doctors in the world. That's what dentistry allows us to do. So I am arguing that the best equipped doctor in the world to plan implants is the person that knows how to do prosthetically driven implant planning, where the restoring dentist is the quarterback, right? It's up to you. You don't have to do the implants. You can refer it out, but you should have a clear plan in mind, whether it's 3 bridges or whether it's a full arch roundhouse thing, whether it's FP2 or FP3. And I will go into an FP1, 2, 3 thing because I realize more and more that even doctors that I respect a lot that are doing, 10 implants a month, that have done several hundred implants, they're getting into full arch. And I ask them, do you know what FP1, FP2, FP3 are? And they say, isn't it based on the hybrid or blah, blah, blah. And I say, hey, let's really think about the meaning here. But the restoring dentist is the quarterback. You can rush, you can hand it off to the running back, you can pass the ball, you can even, you can even take a sack. Don't fumble the ball, but it's whatever we decide to do, given our skill sets and difficulty and complexity, as long as the final treatment plan is planned by the restoring doctor, and that dictates the surgery, the location of the implants, then you're the best plan to do it, right? So the era of the super GP, as you already may know, is upon us. And for the first time, I think about 4 or 5 years ago, is when the mathematical majority of implants being placed in the United States was done by general dentists. And so the time is upon general dentists, if you are, to get into full arch. Okay, what if you can combine many or all phases of the treatment from 1 through 7, what are you comfortable combining right now, right? Number 1, dental extraction, to immediate placement, to custom abutment placement. And if you can do that, you can get a fixed temporary prosthetic delivered. And if you can somehow cheat the body's need to osseointegrate and heal the implants, we do same-day implants, next-day implants quite a bit. And then should you do that, then could you possibly go to the final prosthetic right away or soon? And then if you can do all that, could you somehow guarantee post-prosthetic home care maintenance for the patient? I mean, is the day coming when we can combine 1 through 7 into as short of a time period as possible? And that's sort of the dream, right? In my practice, I've always combined 1 and 2. So 95% of the time, if I'm doing the extraction, I am placing the immediate implant. And I've done about 12 to 15,000 implants, just number of implants, right? Not that many cases. After 10,000 implants or more, I don't think there's any mathematical, statistically significant difference between implant success when I'm placing into a immediate extraction socket versus, bone that had grafted and healed, 3 months ago, 6 months ago. And so imagine what a practice builder it is for me to be able to tell the patient, Mrs. Smith, I can't guarantee it, but I might be able to save you a visit and 3 to 4 months of your life and charge you the same amount of money. I'll try to take out the tooth, clean out the infection, put some bone graft in there, and I can get the titanium implant screw into your jaw, into your skull on the same day. Can't guarantee it, but I'll try. And 95% of the time, that's what I'm doing. But I have protocols, right? So I'd like you to think about right now in your practice, which of the steps 1 through 7 are you combining? Are you doing 1, 2, 3? Are you doing 1 and then always waiting 3 to 6 months and having the patient come back for the implant placement later? And that's all okay. But full arch implantology inherently means that the patient is expecting same-day teeth, albeit temporary, right? And that means you need to understand when to combine these steps or not, right? So, again, these are some of the protocols. I'm not going to read every single box here, but I combine 1 and 2 every time, right? 95% of the time. And I think it's actually easier in some way for me to get the implants, get the strength that I need, and just save the time, right? Of course, I'll have backup flippers and partials and teeth and all that ready to go, right? 2 and 3 I combine, but I have some situations where I won't do it. If I'm not getting the primary stability to work, if the bone density isn't great, if it's a second molar, I won't do it. Just the great majority of implants that fail to integrate early failure, in my practice, are numbers 2 and 15, the upper second molars. And I hate those damn teeth, right? So on those teeth, I'm not going to put a custom abutment. The bone is sometimes buttery soft. It's a D3, D4, D5 bone, right? And so not going to do it. Never on bruxers, clenchers, folks that are displaying parafunctional habits. And if you think about it, folks that are snoring and have untreated sleep apnea, obstructive sleep apnea, maybe folks where you say, hey, yeah, I'm not going to load teeth on day 1, So practically speaking, there has to be a reason for it, right? It's a lot of extra work and also money out of your wallet to get the, custom abutment and the prosthetic prefabricated. And you have to make sure the surgery goes well through a guide or even freehand to make sure it fits well. And you have to pay somebody to convert the case for you, or you do it yourself, which requires a lot of time. And so there has to be a reason. So really, it should be driven by cosmetics and convenience. But what allows you to determine when to do it or not shouldn't be just, hey, I got great torque on this thing, or clear choice and everybody else is doing it, so I'm charging somebody $50, $60, $80,000, $100,000, whatever it might be in your area, so I better give them same day teeth. 10% of the time, these patients come back and there's some issues with the implants, right? And so the goal is to combine as many steps as possible, but the rationale should be evidence-based and really data-driven, right? So I think most people are still at the stage where you are able to combine 1, 2, 3, and 4, but you can't cheat the body's biology into forcing osseointegration. Yeah, there's a lot of tricks out there. People are using UV light to do some magical stuff to implants. There's special chemistry. I mean, there's so much out there, right? We are tricking the body into thinking the buccal plate is intact by doing partial extraction therapy. I do it all. But I still tell the patients, hey, we can't cheat biology. I like for your implants, the prosthetic screws, to heal in your skull for proper amount, 90 days, Mrs. Smith. And after that, we can consider changing out these temporary teeth to permanent teeth, and that material, we can have a discussion. It could be zirconia. It could be a continuous, repeat of PMMA, which are long-term temporaries every year that you come back for, which forces the patient to come back for their recall visits, right? And for a nominal fee, we can print out another set, give it to them, right? Because the soft tissue is going to look different in 90 days, right? And so the way you talk to patients and set the expectations is also key. And if we are converting from PMMA to whatever, zirconia, if there's so much material options out there, then it's important to train your staff and all to talk to patients about, hey, the benefit is XYZ, and the fee to go from one material to another biomaterial, given benefit XYZ, will be another 5,000, will be 500, will be 15,000, whatever works in your practice, right? Because it's value driven, right? So, as you continue to go into full arch dentistry, please think about what are the least predictable steps when it comes to your implant dentistry practice, and tackle it, please. Is it achieving osseointegration, which I don't think is an issue for most of you? Is it ideal implant restoration and prosthetics? Is it simplifying the many steps that are required? Is it long-term maintenance, which I think honestly is a huge thing, right? We don't go home every night and brush the teeth of our patients, no matter how much money they pay us, right? And so I am beginning to see a lot of implants where the surgical component was done well, but man, the prosthesis, especially the intaglio surfaces are just food traps, and it's really just a bacterial, petri dish. And so unless the patient's coming every 3 to 6 months, where you're unscrewing this thing, cleaning it out, and putting it back, really the planning was the issue. So the long-term hygiene maintenance isn't realistic because the planning surgically, prosthetically wasn't done as well as it could have. And I'm seeing a lot of these cases from 10, 20 years ago. But is it establishing a profitable model? Sometimes there are cases where I just, I feel like even if the patient paid some 5-figure number of dollars, 20, 30, 40,000, whatever, and I feel like I made no money because I spent so many visits, so much time trying to fix issues, trying to get the implants right, redoing things that didn't take, whatever it might be. And then there's also administrative and staff issues in terms of selling the big cases to the patients. It is an experience, right? Psychology of marketing and selling big cases is different than just doing crowns and root canals and extractions because insurance is covering it. And then it might be a combination of some of these, pain points for you in your practice. But am I immediately placing or not? Am I placing bone graft material? And if so, what am I using? These are things that I think all of you guys should have protocols in your practice. It doesn't necessarily have to be based on 10 different articles in the literature because they're constantly changing anyway. But you should have some rationale as to why you're calling up your bone graft rep and saying, hey, I want that DFDVA, but can you give me 50-50 for this case? Versus I want 30-70 for this one, right? There has to be a rationale for why you're doing phlebotomy and doing a platelet-rich fibrin on this full arch versus on the other case, I don't think I need it, right? And so these are things that I think we have to pay attention to. So what are some basic reminders? Here are a couple thoughts for you. Every missing tooth site is different, right? Available bone dimensions are obviously different. And we measure that on the CT scan, but the density is different too. And it is mind-boggling to me that when I ask doctors that are already placing implants and I say, okay, yeah, we can get a 4.3 by 11.5 implant in there. But what kind of bone density are you talking about? And they go, oh, you know what? It's the maxilla, it's in the back, and she's a 52-year-old female, so probably D3. And I go, did you not measure that on your CBCT? There's a Hounsfield units function that is an indicator, a directional indicator towards what the bone density might be. Even in the same patient, even in the same arch, even in the same quadrant, one tooth to the other, the density could have a very big gradient, right? Have you ever placed implants in the mandible on a number 19 or 18 or 30, 31 and dealt with have you ever had a situation where you're placing the implant and you're getting great torque and you're getting the last 2 or 3 threads to go and right to the bone level or a little bit subcrestal, whatever your rationale might be, and then all of a sudden it just drops right in and you're like, oh my God, the implant just went 5-6 millimeters south, and you realize, oh, there was a marrow space, right? Just because the cortical bone where you started the osteotomy and you got the implant to go through, it gave you a sense of stability, doesn't mean that it's the same density as you go south, right? So sometimes these days there's more and more of a movement for good reasons to place implants subcrestally, and I'm a big fan of the zero bone loss concepts with Tomas Linkovicius and others. But sometimes you have to be careful because even in areas where you think the bone is dense, a couple millimeters away, you might be dealing with a very soft area of a very little bone, right? So even in the same patient, even in the same quadrant, density might be different. And I'm surprised by how many doctors are not really thinking about density in their decision to pick the number of implants, the size of implants, and the location of implants. And here's one of my favorites. Are you doing FP1, FP2, or FP3? Are you doing all on 4, all on 6, all on X? Are you doing an overdenture or fixed roundhouse, or are you doing 2 or 3 or 4 or 5 or 6 different bridges in the same arch, right? Where should the implants go? FP1, 2, and 3, the number 1 refers to the different types of tissue you are replacing. So FP1 means you're replacing one type of tissue, which is teeth. FP2 means you're replacing 2 types of tissue, so teeth and gums. FP3, you're replacing 3 types of biological tissue, gums, and bone. And so FP3 means you're removing bone. FP2 means you're removing maybe a little bit of bone, but some gum. FP1 means you're removing very little to nothing, right? So there's more and more of a slow and steady movement towards, in the dental implant industry, towards conservative surgery now, where you don't have to remove a lot of bone, meaning what used to be a lot of FP3s all on 4s, cookie cutter, are now becoming FP2s and FP1s, right? But it doesn't mean there's anything wrong with removing bone, but we need to rationalize it clinically, right? And so please know that once you decide whether it's FP1, 2, or 3, then the location of the implants also changes somewhat, right? And so let me give you a couple examples. FP1, you're only replacing the anatomical crown. It's like, what we know. It's the crown, it's the tooth. Only one type of tissue replacing, which is a tooth, right? So we need to think carefully about the emergence profile. We need to think about differences in papilla, cosmetic needs of the gingiva, high smile lines, all that stuff, right? FP2 means you're replacing teeth and gums. So we better add some pink. So this picture is a classic example of, where you need to not only think about where the teeth are going to be, but where the gums need to be. Does it make sense to graft soft tissues, right, before or at the same time as implant placement? I see a lot of doctors who are in their implant journey, in the early stages of the implant journey, they're not really necessarily thinking about gingival grafting, soft tissue grafting, as part of the implant placement. And you don't always need to, but when it comes to full arch, we better do it. We also should think about biotype, how thick, how strong, how keratinized the soft tissue is. And that will also help determine whether we can place some implants or not in certain sites, right? And FP3 is the classic, remove a whole bunch of bone and let's replace it with a prosthetic that not only has teeth on it, but heavy gums on it. And so, the location of the implants matters based on the prosthetic type that you're treatment planning, even before you decide to numb the patient and do the surgery, right? In a case like this, clearly here we should have removed a lot more bone. And so this is not a case that I did, but this is a case that, obviously drives home the point that it is okay for clinical reasons to remove a lot of bone if needed. I don't think any amount of Botox here would have solved the high smile line in the transition zone. So here, an FP1 is absolutely not a great idea. And you can also begin to see that the implants were placed way too buccally and the soft tissue was not respected properly and all that stuff, right? So it's obvious it needs to be an FP3. But even on a single tooth, heck, even if you're doing a mini implant, you still need to think about the restorative space, right? The interarch space. And that is intimately connected to the material that you're using, because you need space for not just the implant, but the abutment, but sometimes you need space for the acrylic or the biomaterial of choice and the framework and some space for hygiene. And so these are things that we really need to consider before we start drilling away. Okay. And so please know that, and I believe these slides and the recording will be available later, so I'm not going to read every bullet point, but the amount of implants is based on a lot of factors, but the location of the implants is also based on FP1, 2, or 3. So in my opinion, in a non-cosmetically critical area, if your implant access holes are coming out of the occlusal surface or somewhere along that arch, that horseshoe, then you're okay. Then it's a perfectly ideal place to be, right? But you know, as you go more and more towards FP2, FP3 territory, then the implant access holes need to be more palatalized or lingualized, right? Conversely, the teeth need to come out more buccally, right? Because you're removing more bone and they need to be in the proper space, right? And it is, especially as you restore the loss of VDO, then you need to consider where the implants need to go. And so I want to strongly recommend that as you are doing your first 10 full arch cases, to consider doing guided surgery, to work closely with the digital planner, but that you as the doctor, you recommend to the planner and to the laboratory that, hey, I know this and this characteristic about this patient. This patient, you know, has sleep apnea. He's a bruxer. He's a clencher. So you know what? I'm gonna place 8 implants on his maxilla, and you know I don't want to deal with a fracture on a, you know, roundhouse zirconia bridge down the road where I have to replace the whole thing, and it's a bunch of lab fees. I'm gonna segment it into 3 different bridges. You know, upper right, anterior, upper left. You know, what do you think about sites? You know, 3, 5, and 6. You know, 7, 8, and 10, 11, 12, and 14. What do you think? Let's talk about how much bone we got, what kind of, you know, where the sinus is, and let's talk. You know, all of that only takes 2 or 3 minutes to make a recommendation on. And then, you know, does it really cost that much more to place another implant or two, right? When we are charging many, many tens of thousands of dollars for these patients, right? These patients are taking out loans and lines of credit on their houses and mortgages, right, to do this. I want to do it right, which means we got to plan right. All right. And this is a pet peeve of all of us, right? And I've done it too, where I left a prosthetic that just had this concave nature on the intaglia surface. And no matter how tight of a fit it was, you know, the upper all on 4 clearly will be a bacteria and food trap. And over time, it's going to cause peri-implant disease. The prosthetic on the lower, which is much better morphology, will give the patient a much more of an opportunity to keep things clean and have long-term maintenance, right? And so here's another quick series of pictures to drive home the point of how this works. A patient comes in, clearly in the terminal dentition, has made some effort to keep things clean, some crown work, but obviously is time to get this going. And so the planning stage really requires a good understanding of where the vertical dimensional occlusion needs to be. And so intraoral photos, intraoral scans, CBCT, so that you can think about where the teeth, the midline needs to go, how tall the teeth need to be, the interarch space, what that needs to be. And then the guide is designed. And usually when you're doing full arch on a limited number of remaining teeth, then I do recommend that you have fixation screws so that you can really have a guide that doesn't move on you. It gives you a fantastic stability. And so this series of diagrams drives on the point. Usually there is a bone reduction guide, as you can see on A and B. And then once you remove the bone to the level shown through the window, now you put a second stackable surgical guide so that you can place your implants in diagram D. You can see there's 3 anterior and 2 posterior implants placed at an angle, very similar to the all-on-4 style. This is all-on-5. And then you will have some kind of a prosthetic that goes over the implants that will also fit nicely on the initial bone reduction guide. So the 3 different guides are stackable, right? It's a combination of tooth and bone retained guides. So it gives you a great chance of getting the outcome that you want. And so this is another view of it, right? But it's driven by that green final prosthetic, where you want the teeth to be. And that is driven by where the patient's midline is and where the patient's size, cosmetically when he smiles, how much teeth does he want to show, right? So, this is 3D printed, so you can see how this works over a model. So again, stackable guides, tooth-borne, you get it on, fixate it with the fixation screws, you take out the teeth, you reduce the bone through the reduction guide, and then you put a second surgical guide over it, place the implants, and load the prosthetic 3D printed teeth on day 1 or the next day or in the future, right? And, we need to think about VDO and the interocclusal space, cosmetically, functionally, and intraorally, the surgery looks something like this, right? The pain point for a lot of you guys may wind up being steps E and F, where once you do the implants, you got the stability you want, and you pack the areas with bone graft, you close it up, and now you have to convert it with a prosthetic. With the advent of digital technology, even in the last couple of years, this has become incredibly easier. And so if you work with a lab and if you have intraoral scanning in your office and you have multi-unit abutments, backup sizes, and you have a 3D printer, you can certainly do this on the same day or the next day. And it's not very difficult whatsoever. Or you can have a lab technician come to your office, pay $400, $500, $600, $800, $1,000 to do this conversion for you, chair side, back and forth between your lab in the office, chair side, and then you go off and see another patient. And so many ways to slice and dice the cat. And so and this is the maxilla, same story. But the idea is guided surgery requires a lot of planning. And because you have this capability, you're really covering yourself because if one thing is a little less stable, now you can make up for that through the second stackable guide and so on and so forth. And by the way, no guides are ever perfect all the time. If you're doing 10 guided surgery cases, 1 in 10 times you might think, you know what, the guide was a little wobbly, and so you might have to take it out and finish the case freehand. And that's why only relying on guided surgery through a splint is also not the most advisable way to go. And so pre-op panel, post-op panel, obviously it's not the full story. The patient will have to come back for final upper and lower if the patient is willing to pay for it and understands the benefits of going from 3D printed PMMA or resin, whatever you want to use, to a zirconium, let's say, right? And so the options are now in your court. The ball's in your court to be able to talk to the patient, convince them of the benefits, pros and cons, and it makes so much more fun. And so from pre-op to post-op, day one, not bad. Some of the frameworks for you to know, mandatory things you have to have pre-op is a CBCT, intraoral scanner. You should take impressions. You should have your staff take photos. And I believe strongly that you should have some backup dentures ready to go. 3D print them or just have some dentures ready to go. Optional, the box was not copy pasted correctly, but there's some other optional things that you should have as well. On the day of surgery, you obviously need the implants, the graft material, membranes, surgical guides, because oftentimes it's going to be multiple guides. You need the scan bodies because you might have to scan again, right? Once you place the implants and you got the multi-units on there, you got the healing caps on there, and you close up and you do your suturing, and you might realize, you know what? The prosthetic that I have here, the gap between it and the gingiva is too big. So I might have to scan, these 2 implants over and then reprint my PMMA. So you got to have some scan bodies, multi-unit abutments, backup sizes. Optional, I like to use PRF a lot, which means you need to have a centrifuge and some phlebotomy on hand. I like to sometimes have backup guides. I've had guides break, when you're doing 6, 7 implants in an arch. When you're trying to get the 6th and 7th implant in, sometimes it's just not that, there's some resistance because there was some movement and it was a little bit less than accurate, right? Always have additional backup implant sizes, abutments, and healing caps on you. And same day teeth, or next day, you want to have the PMMA, you want to have pickup materials to convert it, but you also want to have the dentures. And obviously you've already told the patient, even before you took their money, hey, I can't guarantee it. It really depends on how your body responds. Once I go in there, once I do the surgery, I'll know if the numbers are good enough. But, as a backup option, you walk out with teeth, but it might be dentures for a couple of months. And that's okay too. But if you certainly have a 3D printer on site or a milling machine that you can shorten that, even if the prosthetic doesn't fit. I want to give you a couple of things just in the next 5 to 7 minutes, just to interest you in a few things that I think are pretty interesting, unique. The U.S. dental services market is $175 billion, right? But, if you divide it by the number of Americans, it's only $500 per person. The average American doesn't spend a lot of money on dentistry per year. And if you look at the implant market, guys, the implant market is growing at 11% per year, whereas the dental market overall is only growing at 5%. So the implant market's growing faster than the rest of dentistry, right? And yet, if you think about it, implants are only $4 billion a year. And so if you do the math, 4 billion divided by the American adults, we're not doing implants on kids, right? They're only spending $15, $16 per person per year in America on implant care, right? If you think about it, right? That means if only 1% of Americans, adults, were getting implants, they're only spending $1,568 on implants per year, which means they're only getting the placement and not the abutment, not the crown. The point I'm trying to make is implantology is growing rapidly, but it's an incredibly underserved market, which means you and I should be doing implants so much more every single freaking day. Crowns are breaking every day. Root canals fail every day, right? Even insurance companies will pay for another crown after 5 or 7 years, which means they know that a crown or a root canal is not going to last forever. So at some point, we're going to have to take out the tooth and do an implant, right? It's only 2.3% of the dental spend, right? 4 out of 175 billion is only 2.5% of dental dollars are being spent on implants. What about in the future? What about 10 years from now, right? Absolutely, you need to be doing not just singles and onesies and twosie implants, but full arch implants, same day teeth, right? That's why you're here. And so I want you to start thinking about what that means for your practice for next year, next 5 years, next 10 years. And even the way you talk to your patients, I think matters. Even if you are in an area where implants are only, $4,000 for one tooth, abutment and crown, and that's a little bit on the lower side, depends on your geography. You tell the patient, hey, if an implant only lasted 15 to 20 years, right? You realize, Mrs. Smith, you eat about 1,000 meals a year, right? And if an implant's $5,000 and for the next 15, 20 years helps you eat every meal better, you realize you're only paying a quarter more to enjoy every meal with your friends and your family for the next 20 years of your life, Mrs. Smith. I think it's an incredible investment you need to make on that missing molar. Let's get you started, right? These conversations. And implants have an incredible connection to facial cosmetics and aesthetics, right? So teach your staff to talk to patients about sagging jowls and thin lip volume and witch's chin and perioral wrinkles, and blow up pictures like this and say, hey, you might worry about facial cosmetics, and I think you have a great facial structure, but Mrs. Smith, I don't want you to have extra wrinkles because you're missing a couple teeth. Partial is not going to cut it, right? Maybe as a temporary measure. I want you to think about getting that implant, 4-unit bridge on 2 implants done, 7, 8, 9, 10. I don't want you to look like you have, a very shortened face in the next 5, 10 years, Mrs. Smith. I really think you should do implants. Do you realize wearing dentures means your face is going to shrink, right? Americans spend way more on facial injectables, right, than they do on implants. Remember, 4 billion in implants, 15 to 25 billion on facial injectables. I'm not talking about injectables to your buttocks, just on the face, right? And it's growing at 15% a year. Americans are spending 15 billion a year on facial cream and cleansers, whatever crap people put on their face. And they're only spending 4 billion in implants. That's a problem. We dentists have an incredible opportunity to convince patients that this isn't surgery, this isn't titanium, this is confidence, better nutrition, self-esteem, and facial cosmetics. And this global market for implants, which is incredibly underserved, warrants that you and I do more implants in the future. So I just wanted to show a couple of these slides because right now Americans are spending 7 to 8 times more on facial cosmetics than dental implants, perhaps because we're not connecting dental implants to be an incredible part of facial cosmetics. Those two things are intimately connected. So a personal pearl as I wrap up this conversation is that being a dentist means we can be experts of microsurgery and awake patients, providing affordable care all day long for reasonable fees. And other than unwillingness to pay, which means it's not just the patient's fault, we need to convince our patients that it's worth the 5,000, it's worth the 50,000. Why should my patient population miss out on this amazing global trend of facial aesthetics and cosmetics and function that no other doctor can do? So please have a protocol. Linkstone Implant Academy, Donovan alluded to this, is a study club that we've just celebrated our 50th live surgery course. Every course is very small, 4 to 6 doctors, ratio of 2 to 3 doctors per instructor. We have these key basic concepts, 30 of them, and we have 365 pearls, 1 per day when it comes to implantology. But have protocols in your office that you can always rely on, right? Always rely on, right? I'm sharing 4 or 5 or 6 of these. Back it up with literature and lay articles as well. It doesn't have to be heavy-duty scientific articles from PubMed. Have some textbooks on hand. A lot of doctors are placing implants, but when there's a complication, they're quick to refer it to the area oral surgeon or a buddy down the street. But I say, do you have a textbook? Do you have some articles for implant complications? Do you know how to categorize the different degrees of complications? And so I say, get some textbooks, right? Download these things. Even one book can set you apart. I mean, this zero bone loss concept model has really taken the implant world by storm. And I think there's a lot we can learn from this set of ideas. and be evidence-based, right? Google the different scientific, criteria for success versus failure, right? What is implant failure versus what is success? If I'm only losing 0.1 millimeters of bone per year, is that failure? Is that considered successful? It's considered successful. Persistent repetition is key. I feel that just like Malcolm Gladwell said in the book Outliers, if you do something 10,000 times, you spend 10,000 hours, that's the magic number, you'll be an expert. Whether it's riding a bicycle, placing implants, whatever it is. So you do have to do a lot of it. But each time you do it, you not only do you do it better, but you think about, did I plan better? Right? And so there's many different ways to think about it. And for the sake of time, I'll just breeze through these slides, which will be available to you. But keep your hands fresh. And if you need live surgery training, there's so many good courses out there. I am just one of several, one of many that are offering it. But please reach out to myself or Donovan. And we do these courses throughout the year. I'm not the only instructor. I am the founder. Linkstone Implant Academy. It's always customized, small scale, judgment-free, mostly general dentists who want to up their surgical game. We do it in the Dominican Republic. And, folks that have been part of any of my lectures, including this one, there is a referred doctor fee, so you get a discount. You're eligible for that for 1 day live surgery training in Massachusetts. We provide all the patients, all the implants. You come, you're ready to place, right? There's the flagship 3-day course in the Dominican Republic, $12,995, up to 20 implants. But for folks like you that are referred, part of our alumni network, it's $9,000. And so there's a lot of these courses out there, and I'm one of several that do these courses. But I hope you would consider not mine, but any course that will continue to improve your ability to do surgery, do restoration, but plan the right way. Right? So dentistry is an amazing field. I've been able to go to a lot of different countries on the missions perspective. Haiti, after the earthquake, a country between South Korea and China that I cannot name here. Dentistry has been an incredible blessing to be able to do it. And I'm proud to say that we're even teaching implants in third world nations like Haiti. Even Haiti wants to learn implants. So we're in it at a right time for us, various different places where I'm lecturing. So all of that to say that it's been a pleasure spending some time with you to talk about full arch implants. I hope some of the examples and frameworks that I presented were useful to you. And don't forget that we are really in a great opportunity. Even though the dental field has some challenges with the rest of healthcare, we are in a great opportunity to really not only make a difference in patients' lives that no one else can, but if you're a surgically trained general dentist who restores implants, man, no one can touch you as long as you can treat and plan the right way for full arch. No one else can do what you can do.